I don't know how many of you are familiar with, we have the infamy of being a largest contributor of TB problem globally. Okay, India has that infamy. A fourth of all those cases that happen globally on tuberculosis happen in India. Yet at the same time, TB is a very rare disease at the population level. So we have these dual problems. Aggregate, it's a big problem, but relatively, it's a relatively rare problem to find. Many people are coughing in the room. I'm one of them. How many of us are going to have tuberculosis? Okay, so think about that as being one of the major challenges. A few years ago, a second challenge was realized, which is of these 1/4 of the global cases, half of the cases are diagnosed/misdiagnosed and treated in the private sector in India. So what that means is, if we have private practitioners in the room, do we have any private healthcare providers in the room? Can I get a show of hands? Yeah, so these people are collectively treating 1/8 of the global TB burden. Okay, think about that. And when I say private sector, I'm not talking about the Maxes and the Apollos. I'm talking about, let's see if I can go back. I'm talking about providers that you see in the picture. Okay, also. So there's a long tail of private providers in India, and that's really, again, highlighting the magnitude of the problem. Roughly 10, 11 years ago, to understand the nature of this problem, TB was made a notifiable disease, meaning the government said, if you find a TB case, you got to notify it so we can keep a register of all cases, right? As you can imagine, those who are in the public sector obviously started this notification business, but private sector took on this slowly. As a result, you had this, missing million problem. There was a large gap between estimated incidence of the disease, estimated based on some, data methods and statistics, and the actual number of notifications. And so some of my colleagues did a very elaborate study. They took a very creative approach. Rather than looking at TB patients, they looked at the sale of TB drugs. And they said, well, those drugs are being consumed by someone. Let's try and estimate how many people would be there if all those drugs were going to some patients, some TB patients, right? And that's how they came up with the estimate that roughly half or even more of those patients that we say exist in India are being treated somewhere in the private sector. But it's still missing. We don't know where exactly, but they are somewhere in the private sector. And then that sets the stage to say, if we want to defeat TB, although we have a very strong, robust TB control program, which now is called the National TB Elimination Program, that program must find itself out of their offices and rooms and go into the world out there and do something with the problem. We have a very strong program, but are patients coming to our program, or are patients going wherever they go? Again, I can ask this question to the audience. If you're coughing, where will you go? Is your first port of call the TB program? No, it's your neighborhood doctor most likely. So then the program says, I will go where the patients go, and then I will have to change the way. That's the origin of private sector engagement. Okay, it's to help the patients eventually. Okay. It's not that the program had not tried to engage with private sector in the past. In fact, this is a study, again, by some of our colleagues, way back in 2006. 7, where they showed that those prior private sector engagement programs had not worked or had provided mixed results. One of the key reasons, and I hope that we will expand on this during the panel discussion, is because what the program was asking private sector providers to do was not palatable to the private sector. For example, they said, if you find a coughing patient in your private practice, please send them to the TB program. No doctor is going to do this, right? Again, like I said, of all the coughing patients, only a small fraction will be those who may have TB. And the moment I refer this patient to a public program, I'm most likely losing on the revenue. Not only losing on the revenue for this instance, for this episode, but who knows future episodes, because patients will say, hey, don't go to that doctor. That doctor knows nothing. They just send you to the government hospital. So again, this brings you to the point where one needs to understand the world of the other partner, if there has to be a true partnership. Okay, so thankfully these things were recognized, and they said we got to do a 2.0 of private sector engagement. And the beginning of that was in the National Strategic Plan for the TB program in 2012. Again, some people sitting in the room contributed in the background towards making this happen. So this language was very carefully chosen. I've underlined some language here. So the first one says the engagement of the private sector must be at a scale commensurate with the importance of private healthcare provision. So this is recognition at the top saying we can't wish away private sector. Private sector is there to stay. And hence, if I go in a city, even if you take the Tri-City area and say, I have a private sector engagement model and I have engaged 50 doctors, it's a non-starter. The scale must be thousands, 5,000. How can I engage at that scale? And then, although we do care a lot about rural areas and we say, rural areas do not have adequate number of providers and healthcare is a big problem, they started with the recognition that we must start in urban areas because of the peculiar epidemiology of TB. And also because private sector is densely available in urban areas where patients go. So some of these tenets were very early recognized to create an idea called private provider interface agency. Government is notorious in engaging with private sector because they don't have the necessary skills nor the scale. If I say go and engage with 5,000, 6,000 providers, they'll say, I don't know where to start. I don't have the staff. So we come up with new organizational mechanisms, new modalities, and this one was proposed as a starting point. The model, I'm not going to get into a lot of detail, but the model had patient at the center, and it recognized, again, the landscape of private providers. So it said there's going to be a hub and a spoke arrangement in some cities. Hub means maybe chest specialists who see complicated TB cases, who treat TB cases, but spokes are those where patients first go not knowing that they have TB. So we got to track the patient journey and accordingly create an operating model. Follow the patient. Don't ask the patient to go to different places. Go where the patient is going. Okay. Of course, this was a learning exercise. This wasn't a full-blown implementation. We called it a pilot then, supported by the Central TB Division, funded by the Gates Foundation, because it was an investment under uncertainty. It wasn't clear if this experiment will work. And then there were, some people like me who were, like I said, on the sidelines trying to understand what's going on, monitoring, learning, and evaluation of these pilots, and the kind of questions that we wanted to address. So while we call it research, this research was really embedded in day-to-day operations. One of the questions was, by engaging with private sector, will I be able to diagnose TB earlier? If those are the first points of contact, I want to be able to reduce the diagnostic delay, because every day of diagnostic delay reduction reduces the infection, transmission of TB in the community. Can I measure it? Can I see by how much I can reduce the diagnostic delay? What particular behavior of private providers do I need to change? What will make them diagnose TB earlier? What will make them suspect that someone has TB? As a result, what kind of diagnostic tools and devices will they have to use? What are their incentives to use those kinds of tools? If they don't exist, can I provide such incentives? And then projecting it out. So the theme is 2047. That's too late for TB elimination in India, according to the government. They want to eliminate by 25. So we'll see. But the question is, I can't wait until then to see, has TB been eliminated? That's not the right question. The right question to ask is, if I do A, B, C, D, what's the chance that we'll be able to eliminate? Otherwise, start modifying your actions right away. So, and then of course, not all of this is going to come for free. There'll be costs. So in health, we talk a lot about cost effectiveness. I hope you've heard the term, but we have to remember that cost effectiveness doesn't mean cost saving. So cost effectiveness implies that I want to put more money today to gain some health benefit later. How much more do I have to put in? And with the sort of premonition or sort of preconceived notion that private healthcare is more expensive than public healthcare. So if I engage with private sector to diagnose more TB cases and treat more TB cases, will it be more expensive to the society overall? So those kinds of questions were asked. I'm not going to get into the details. I'm just going to give you a glimpse of the kind of work that we did. So a very large scale community-based survey was done, first to find TB patients, whether in public or private sector, and then trace back their patient care pathways. Which doctor did they see when they got diagnosed? Before that, which doctor did they see? Before that, which doctor did they see? How many doctors did they see overall? How long did it take for them to get diagnosed? Because that kind of information was useful to then say which provider should we target. And if we target certain types of providers and not others, by how much can I reduce that diagnostic delay? So that was one type of research that we did. The other type of research we did was, how do I start changing the practices of private providers? Pharma companies have done this for long. They send sales reps to pharma companies in a bid to change their prescribing behavior. Can we use similar ideas but for a public health goal? If I have a new diagnostic test for which the doctor is not going to necessarily get any commission, can I convince those doctors to start prescribing this new test, or even sometimes directing the patient to a public health lab just to get this test done, and then the patient can come back with the result to them? And so we looked at the effectiveness of such models to change provider behavior. The other interesting thing is, a diagnostic test only gives a result. That result is an input to the decision making of the doctor, right? So we don't want to incentivize the doctor only to order a test. We also want to ensure that the results of the tests are integrated in the decision making, the diagnostic decision making of the doctors, and to what extent is that happening. So as those pilots were unfolding and the data was coming through, we were looking at these things. We were looking at how the decision making of private providers is changing. Where is it changing? Where is it not changing? And as a result, again, do we expect a large scale change to occur, both in terms of diagnosing of patients, but also then eventual successful treatment outcomes. Finally, cost effectiveness. So we did a fairly detailed costing analysis. These pilots, again, that were running, those were our labs. We sort of went and did field studies. We interviewed people who were running these pilots to understand the cost structure at the current scale, but also cost structure as these programs will scale. And then also did a fairly complicated piece of epidemiological modeling to say, if these efforts were scaled at the population level, by how much will you be able to reduce incidence, transmission in 10 years, 15 years? And then if I put these things together, will there be an overall cost effectiveness? And for those who may not be familiar, there are standard methods, disability adjusted life years per dollar or quality adjusted life years per dollar. So those calculations we did, which can then go back into advocacy and policy communication to the government, saying these two pilots are showing that certain interventions are cost effective. So you got to do something about it after the pilots end. Right. And pilots were successful thanks to efforts of many people who are sitting in the room, not me. I just documented this stuff. And then luckily, things didn't stop here. The next step, I'm going to skip through this. The next phase was scaling up this pilot, which was itself at reasonable scale, but 2 cities is not India. Right. So then a lot of effort was taken in the background to say who will fund the next level of scale up. And this happened across dozens of cities, in at least a dozen of states, where a similar idea of an interface agency to engage with private sectors at scale was taken up. And the funding was obtained from Global Fund for AIDS, TB, and malaria. Again, the government was very, very centrally involved in overseeing this program, in ensuring that these efforts are integrated within the running of the program. That it's not happening separately, that it's integrated with the program. And then eventually after that, the third round of scale up was a big loan from the World Bank directly to the government. So now look at this, okay? Initially some grant funding to experiment, then a more scaled up financing, multilateral financing to ensure that these ideas are indeed scalable. And after that, eventually the government owning up and saying, okay, we must do this. This can be done. This has the desired consequences. So we will take a loan from World Bank to then scale it up further. Okay, so that's really the pathway. What we've done, and I'm not going to spend time now, but hopefully in the panel discussion, is to say this TB is just a use case. It's just one application, one disease. We started now studying, can similar ideas be applied in other disease domains, and especially non-communicable diseases? So those who are interested, I can talk later about hypertension, about diabetes, about nutrition. So if I want to increase fruit and vegetable consumption in rural areas or peri-urban areas, can I similarly find a way of engaging with informal vendors who sell fruits and vegetables on the street and figure out a business model? Because the whole idea here is of creating a win-win. Is this a good business opportunity for those private players? And in turn, does it help the population to improve their own health? Okay, and that's really the challenge in initiatives like this. With that, I'll pause here. Thank you for patiently listening to this monologue. I promise you the rest of it will not be a monologue. It will be a multi-log. So with that, I'm going to invite my panelists. Please, Dr. Shibu and Dr. Sudha Chandrasekharan. I would like them to take the seat. And we have Mr. Pardeshi, who's joined us remotely. He couldn't be here, but he's graciously agreed to join remotely. So I've got three accomplished panelists, Dr. Shibu, Dr. Sudha, and Mr. Pardeshi. If I went through their introductions, I will be spending the next 1 hour. But I'm going to introduce them as I ask questions, because that's, I think, the most relevant introduction for this discussion. Dr. Shibu, by the way, he's one of the key orchestrators in the big, thing that I described. He was leading one of those private provider interface agencies in Mumbai, and so that's why I'm going to start the question with him. Shibu, you've before this big initiative, you actually worked in the public sector, correct? Right? You were a district TB officer, correct? And so you would have seen the other side of public-private engagement, and then you moved over to the dark side. I'll just call it that. We are in a business school, so I'm allowed to say that. My question to you is, when these pilots were being conceived and designed, and now you look back on them, what were the key differences in the way private sector engagement was approached as compared to the earlier approaches? Would you start with that?
Yeah, so I recall my days as a district TB officer. That time also there was a private sector engagement strategy. So it started in 2003 by Government of India, supported by bank, and then supported by WHO and CDC and other partners, recognizing there is a threat outside. But as you mentioned, it was old. So you come, you refer. And also started actually shaping up to you refer, we also kind of offer services. So refer and offer, right? So again, I can give you drugs and logistics. Then it evolved to, okay, you start your lab, TB lab. I will offer you money for it. I will assure you quality assurance. So we moved a little bit beyond. But none of these strategies was working because of the bandwidth issues and the behavior from the government side. So government is constructed, okay, this is those patients who are coming to me is a primary service client for me, and I have to satisfy them. And I have constrained with that budget, right? Okay, so in the moment I overstretch to extend it to the private sector, that's on me. Like, why you want to do that? Because that's a behavioral issue. So, and again, the behavioral is all regulatory. Well, you are doing a wrong practice, right? Okay, so I'm offering the right services, this is wrong. But in clinical practice, you won't see the same, the two different doctors behaving the same way in approaching the same patient, maybe same disease also. There'll be subtle differences. So that was something government standardization jacket versus the private kind of freedom to treat my patient in my way. That is a disconnect. There was a disconnect between the drugs also, because the popular drug regimen in the private sector was a daily regimen versus the government was pushing twice-weekly regimen, which was perceived as suboptimal. And then government changed over a period of time. So the key change was realization there is an issue, which you said. And 2009, there was a joint monitoring report which came from external experts used to evaluate TB program and say, hey, that you have been doing something, but it's not working. There is no evidence. But your problem, you are stagnant in your case notification, your reach. The problem is not with the public. The problem is outside. Okay, so what is the change? And they articulated clearly, you don't have the bandwidth. You have to have an interface agency. So it came from a bank study. Actually, bank initiated that. I was fortunate enough to be a part of that, orchestrating that when I was in ministry. So they came up with the document saying interface agencies could manage it. They cover up with the behavioral issue the government approached the private. They also said, okay, so it is, because that's not your construct, that's not your skill. Okay, so you, entrust people who have that skill and let them go and at scale. So, and then we got the Mumbai opportunity. So the key change was kind of understanding there are different animals in this ecosystem and approaching them with their needs. they're not disturbing their patient workflow. So that's a key thing. So rather than asking, you do 1, 2, 3, 4 things, say, okay, fine, do whatever you do. But if you do in this way, retaining your patient, so there is no clientele snatching.
Mm-hmm.
So asking them to retain their patient and say offering what they like. So Sarin was part of the study, like what are they offering? So what do they do when they see a coughing patient? They don't go and prescribe a smear test for TB. They will approach with an antibiotic trial or some steroid trial, and then they go for an X-ray. So why don't you offer X-ray upfront? Can you do that X-ray maybe in 2 days rather than waiting for a month? So offering right incentives to actually targeting the right behavior. So the right behavior is to get the diagnosis earlier, which you mentioned that, and also notify. So notification, though it was a regulatory approach from the government. So government came up with regulation, then kind of incentivizing the both carrot and stick approach. On the regulation side, it's just a paper statement saying you need to do that. And how part was not being addressed. So there comes the interface agency helping them and do that. So distinguishing between the clinical responsibility, leaving the clinician to do the clinical responsibility, interface agency taking the public health responsibilities, including notification, searching for the patient's contact, linking them to HIV, diabetes, making sure they are sticking on the treatment was the key distinguisher from the earlier approach of refer versus, okay, fine, there is a support system for you.
Thank you, Shibu. A couple of things I'll highlight. We talked very briefly about outsourcing. So I think the conventional notion of bringing in private sector is to outsource additional load that I have. But the load is only patients coming to my centers in the public health centers or people who are out there in the population. I think that was the big change. And the other is friction that exists on technical grounds. So sometimes I'm not engaging with private sector because the evidence that they see is different from the evidence that I see. As a result, the standard operating procedure and the clinical guidelines that I will come up with may be different from what has been practiced in the private sector. And unless those two are reconciled on the technical front, it's going to be very difficult to engage on an operational front. So Shibu, thank you for bringing those up. I will come back to this later, but I think he mentioned Mumbai, the government entity that you engaged with in Mumbai. Could you talk about just briefly?
So Mumbai was always an exception because they had an issue with totally drug resistant tuberculosis that actually triggered the entire conversation. That was in 2011. And they clearly were up in their arms and said, hey, I have an issue which is being triggered mostly by the private sector. I can't handle it. But government of India was kind of like not denial mode, but again, not endorsing that theory. But eventually foundation, BMGF and said, okay, we will support you. And one of the strategies, so the entire scheme of things was actually packaged under Mumbai Mission for TB Control. So there was a larger piece, and wherein private sector was one among that. And even they were not even confident to call it out as a private sector engagement. They kind of subsumed it under urban TB, slum TB control. So the moment you call a government calling out a private sector engagement, they will be bashed by the bureaucrats. Because no, we don't have bandwidth, we don't give money to them, don't go to them, they are bad. So they kind of cleverly done that. There is a lot of people actually work towards with the BMC to construct that. And then they were super supportive in doing that because they know that there are skill set available. So they also did not only recognize there is a problem being triggered by the private, they also see it. So there are solutions within the private. So I think that, kudos to the Mumbai government officials at that time and also now also, they were actually kind of teaching lessons to the larger TB control program across the globe to say how we can leverage private sector and coexist.
Thank you. When we think about public, when we think about government, most of the time we are thinking about Delhi. And then some other times we are thinking about the state governments. But this is an example where the city administration stepped in and turned out to be a key stakeholder. Now, of course, we can argue not every city is Mumbai and they don't have the budget that the municipal corporation has. But every now and then there may be an opportunity even at that level that we can tap into for health outcomes. Thank you, Shibu. So I'll come to you next. You also have a history and experience in public sector. You were medical director for the Suvarna Arogya Suraksha Trust in Karnataka. And in that capacity, and later, of course, at NHA, Director of Health Policy and Hospital Engagement. So you have also been on the other side trying to engage with private sector, but in a very different space. So in a tertiary care space, here we are talking about outpatient. There, I think it's more tertiary care hospitalizations. In your interaction, what have you heard as being key concerns from the private sector? Because we often hear lukewarm response. So we want to hear from you. And then what could you do creatively to address those concerns and bring private players on board, if you can relate to that?
Thank you, Sarah. Basically, when we talk about this kind of engagement where the government is aware that they cannot do many things, but they have to ensure that they have to work with the private sector. So how that kind of a very hot cold relationship is what I can see. They know that they have to engage, but they don't know how to. And ensuring a good partnership is completely something that it comes with some degree of engagement, and you learn across as you go along, because different private sector engagements are also different. So health is something that is like always seen as governments. It's the responsibility of the government to deliver these services. But then we realize that tertiary care is something that, however, in the next few years, still we will not be able to, scale up our systems to that. So in that sense, and when governments want to promise some things to the public, saying that we do give you free healthcare services, including tertiary care, then they get to realize that how do you engage with them? And I think in that sense, one of the things that really helped us to actually engage better was having a good contracts with the private sector. So they knew what they could do, what they could not do, and they knew how much they would get to be paid for, and how they are a part of that negotiations for the kind of payment structures that that they can expect from the government. So many a times it happens that yes, we work on volumes, but whereas the private sector thinks that this is my rate, this is how this is the basic minimum that is required for me to deliver this services, but what you're giving me is like nothing. Whereas the government is saying this is your unused bed capacity, 40-60% is what you normally have but we are going to push volumes to your hospitals if you engage, so you get a better from empty beds. So in that sense, these kind of negotiations happen over time, and you learn over time on what is the best way to actually work towards that. So in that sense, also looking at having these contracts and having a kind of oversight, because we did have a disciplinary committee, because we also knew that not all private will engage in bad practices, but still we need to have kind of an oversight committee to look at if there are deviations, if there are grievances from our beneficiaries, how do we engage them and how do we address them? Because finally we're accountable to the public, right? Private sector is, yes, our friend in this whole exercise, but we also need to ensure that we can work with them with the kind of both sides. So being soft on them, especially when we need to work together as a part of partners, but also may have some other mechanisms to ensure that these kind of deviations don't happen. One of the kind of, the study we also did as part of the World Bank during the COVID is how are governments engaging with the private sector in different states. So there are many kind of instances, because some states went all out and said that, okay, give your keys and your hospital and your staff, and then, public big government would take care, and, we would need to have all the beds that we can to provide these services. Whereas other governments sat together with the private sector and engaged them and say that, yes, we need to work on this together. So, what is the best we can do, and what services will you provide, and how can we have a good referral system, so that once our capacity in our public facilities goes beyond, then only we will try to, push it to your sector. Otherwise, you're free to do what you're doing and, handle the patients directly who come to you. But any patients who are referred from us, you will only charge us the rates that we have agreed upon. So these are different ways of engaging the private sector and making sure that, we have a very good understanding. I'll just shift to a national level a little bit, because at the national level, when we come out with policies, do we really engage the private sector when we are finalizing these policies is also very important. Because during my stint, we very clear that we need to have the stakeholders' participation. So when we put out the policies, I think there were 2-3 very key policies. One was on the value-based care system for patient care, and also one was on health technology assessment policies. So how do we involve newer technologies to be a part of the healthcare reimbursement, and how do you work with that? So I think those were various where we engaged very closely, and we responded to each and every query of the stakeholders who wrote to us. So, that's something they really appreciated, that you took the time, effort to actually speak to us, listen to us, and then respond to us. I think communication is really a key in engaging private sector. I think it doesn't come automatically among all officials in the government, but that is a skill that needs to be developed. And Sarang was saying that they're going to come up with a lot of courses to even engage the state officials on these kind of soft skills on how to engage private sectors. So it is very important that these are two varied experiences wherein we are one-to-one with at the state level, but also look at, at the national level, at the policy making level itself, to engage maybe some of the other side in terms of the not so good side of the private sector. I'll take it up in the next question.
Yes, we will not let that go. Yes.
So this is something which I feel that, as a first round of discussions, it's important that both sides realize that they can work together on this.
I think some common themes are already emerging. For example, both talked about carrot and stick approach, right? And for the carrot approach, I need to understand the business model. I think she, although she's a doctor, she very deftly talked about marginal cost versus average cost-based pricing, right? And that understanding needs to be there, both on the technical, clinical front as well as the business front. And the community.
Sarang, I'm an economist also. So that was one of the reasons that I could bring in those kind of discussions into the negotiations.
There you go. Yeah. Thank you, Sudha. And that's the point that I want to bring out later in the discussion about the capacity that we need in the public sector to be able to have these meaningful engagements with private sector. Thank you. Mr. Pradeshi, if you can hear me, I'm going to come to you next. And I'm going to switch gears a little bit, because the case study that we talked about was TB and infectious disease, and then we talked about hospitalizations. The diseases of the present and the future are not only communicable diseases in India, but they are what we call as non-communicable diseases, diabetes, hypertension, the whole plethora of diseases. And until a few years ago, we used to call them, incorrectly as diseases of the rich, diseases of affluence. And it turns out that that's not the case. These diseases are afflicting everyone across the board. Same is the case also when we think about private sector. There was a very incorrect mental model that rich people go to private sector and poor people go to public sector, which is absolutely not true. And there is a whole sort of heterogeneity in the private sector when it comes to patients going there. So, Mr. Pradeshi, I'll come to you and I'll ask sort of a broad question first. Given the range of non-communicable diseases that exist, so you have everything from hypertension and diabetes to respiratory illnesses to cancer, at a policy level, how does one even start deciding priorities? Because again, as we said, cost effective doesn't mean cost saving. So you got to put in money, you got to do investments. Now, could you talk about, in your experience, how have governments thought about prioritizing non-communicable diseases battle, knowing fully well that bilateral, multilateral, philanthropic donations come less in this space? A lot of that money still goes into communicable diseases. So if you could start with some ideas on that, prioritization within non-communicable diseases. I hope you could hear me.
Yeah, I could hear you. I was just cross-referencing some of the things before I got in. So the person you have on your panel, Mr. Shibu, is from this unclear. So both the examples that he was giving about tuberculosis in Mumbai, I was the municipal commissioner then. And Fidel was their parent company who incubated them, and I supported. In fact, I engaged Fractal, and that's how they incubated them to do this. It was a very experimental approach at that time for not just TB. TB went on later. Municipal Corporation has a big TB program. The real issue right now is drug-resistant TB. The rest of TB is more or less a sorted out case. But the drug-resistant one and adherence to protocol is an issue. And I don't know how the private sector helps in that. It's actually the government and public hospitals which are pushing them for adherence. People just disappear from the drug-resistant category. That is, you're not able to track them continuously. So that's an issue. But let me come to more exciting issues, which is what you started with, the non-communicable disease. And that's exactly what I wanted to talk about today. So I'll just use a couple of slides. Can we? I think the screen is shared. No? Yes. Can we just move forward on this? So first is about non-communicable diseases. So what you see is a very, I did this research when I was in the UN. After being in the Mumbai Corporation, I worked with as a global program coordinator for the UN for non-communicable diseases. So this is something I was doing this sort of a research, just a desk research, and I found this exciting correlation. So, you know, the graph, the yellow line graph is the COVID case fatality. So, for example, Singapore has almost point something COVID case fatality. That is, out of 100 COVID cases, hardly anybody died of COVID in Singapore. On the other hand, a country like Pakistan had, for every 100 cases, at least 2 to 2.5 people died of blindness. So that's not interesting, that we know. And that also correlates to the health system. But look at it, how it correlates to the underlying non-communicable mortality burden. So Singapore has a mortality burden of just 180. This is premature, what you were talking about. The premature mortality due to non-communicable disease. That is, if the average longevity of Singapore, let's say, is 80, and if you die before 80 of diabetes or of whatever, then it's a premature mortality. So this is 186, which is one of the best in the world. That is, for a population of 1,000, only 186 people ever have this. On the other hand, if you go down to a country like Pakistan, it is 716. India is somewhere in between. India has done a lot of work. So you see that India's case fatality is around only 1% in COVID. So this is a fantastic achievement. People were doubting this, that this is not true. But statistically, it was true, because the underlying NCD mortality is still not at the level at which it is in other parts of the world. Can we go to the next one? So now we did another research on various across the different countries. So what we found is, as the annual NCD mortality rate goes down, the amount of COVID case fatality rate goes down substantially. So, so this is a country like, let's say, Brazil, which is 60 million people and which had a COVID case fatality rate of about 24 per 1,000. And their annual NCD mortality, if it was 5 per 1,000, then they had almost 144,000 deaths. But if you see this, if the COVID case fatality goes down to 3.75 per 1,000, then the number of deaths come down substantially due to COVID, which is only 108,000. And a country like that is Paraguay. And finally, you look at a country like Rwanda, of all times an African country. If the COVID case fatality is 2.5 per 1,000, then you see the number of deaths which go down absolutely to manageable levels, which is 84,000. So what does this tell us? It tells us something which the world is not doing. So for accessing the universal access to health for all, we require a certain amount of budget, which was roughly around $371 billion. But do you know that just for COVID, we already spent 10.5 trillion when I did this work, which is 2.8 times what is needed for universal access to health. But we spent it only on COVID, which didn't get us the universal access to health. So this is what I wanted to propose today, that it's all the viral diseases which are going to come now in future because of climate change. How do we scale up public health in a way that it prevents underlying disease mortality, underlying health parameters. Singapore is a country which is very high on its overall health parameters. So let diseases come and go. Not much is going to happen to them. And a country which has very high mortalities or reflected indicator is the high mortality rate, then whatever it does last minute for the virus, it's not going to prevent mortalities and destruction. So this is what I did in Mumbai, for example. We use unclear and fractal to ensure that we could detect COVID without having to do the COVID test, because COVID tests at that time was very much, in the first 3 months, it was very difficult to get people to do COVID tests. And then if many people went for COVID testing, then they also infected everybody in the hospital and the doctors included. So we wanted to have a triage where we could separate out. So artificial intelligence was applied, and application was developed which through just an X-ray, a portable X-ray, could identify 40% probability of COVID. So only those people then needed to go for testing, while the others could be palmed off. And this was done along with unclear, but mostly with fractal. So my proposal today basically is that, sorry, can you go up? So that AI and telemedicine is the one thing which the private sector needs to adapt from the public sector. So today, Cure, see, Max, Hospital Max and all of these others, they're still focused on tertiary care. Do you know that 50% of women in India come for cancer treatment at stage 2 or 3, when they are going to die in any case? But in USA, they come mostly at pre-cancer stage because of continuous monitoring, and therefore they don't die. Because cancer can be treated. Now we're trying to do that in the non-communicable disease program, but there the intervention for health is not anything to do with medicine, what you are all talking about. It's only about diagnosis, and diagnosis newer ways. For example, cervical cancer now can be detected through visual inspection if we have acetic acid, and the probability can be brought down to 8 or 10%. We don't even need to do a biopsy. And if we can detect cervical cancer at a precancerous, that is first stage 1, then simply a TA, that is thermal ablation, which is recommended by WHO, which takes only half an hour, can completely cure the person, and that person is no longer same lady. If she comes to your hospital when she is suffering a lot, then you can only give palliative treatment. So how do we enhance the private sector's capacity to provide diagnostics support to the public health infrastructure? For me, this is the key question today, not curing, not treatment, but enhancing detection and of non-communicable diseases in our very robust public health system, which is the primary health system. But they don't have the diagnostics of these sophisticated, like breast cancer, oral cancer, etc. There's only one hospital which is 50 kilometers away. Then women are very shy to go there, so they avoid going until it becomes too painful. By that time, it's too late. So this is the place where private sector, through AI and through our public stack, you see what the finance department has done. They used the public stack, which is access to we can now get rid of this, access to the entire digital infrastructure, and ensure that everybody can get direct DBT payment. Can't the system step in the same way and use India's public digital stack to penetrate diagnostics to women between 30 and 60 in every rural area, so that you can identify precancerous, breast cancer, cervical cancer, and of course hypertension and NCD. And then the pathway to cure is so small. After 150,000 such tests in Usmanabad district, there are only 2 or 3 who need actually a biopsy for cervical cancer. Similarly, we did the same thing in Bhopal, but we don't have the capacity to do this regular annually, and 3,000 women checked for cervical cancer or breast cancer or for hypertension on a continuous year-by-year basis. So this is my problematic to you. Government is of course trying. Government is also trying to do the diagnostics, but government diagnostics always has a problem in relation to getting people involved and ensuring that it happens at a local level, at the village level, and not at the city hospital level. Thanks.
Thank you. This is I haven't seen a cleverer case of investment in NCD as pandemic preparedness. I think that's very clever. If you got it, right? So if you invest in NCD management over the next 15, 20, 25 years, then you can expect lower mortality from the next viral pandemic that may come. I think that's one of the many business cases that could be made. Mr. Pradeshi, I have just one quick follow-up question. Screening is absolutely important. And so if there are entrepreneurs in the room, he's already made an offer that there may be business opportunity for you to scale up your technology, etc. I'll come to audience questions later. But the point I want to make about NCDs and to draw a contrast with TB type diseases is many of those don't get cured. Right, so you screen, you diagnose, and then you have to manage the disease. So, Mr. Pradeshi, the question to you is: can we think about different private sector engagement models where we can have these private players play a role in managing the disease over many years, in a way that is still profitable for the private sector but is health enhancing for the population? Could there be some ideas around that?
Yes, absolutely. So actually, I was trying to point out a quick win, a profitable quick win for the private sector. And one of my very close friends, Mr. Venkat, through Karkinos, is already working on that through his through the company. So what is the basic issue of NCDs? Of course, management is important, but that's the long haul. And there's not much, let me tell you that I don't think there's that much profitable business models on that one. And then there is the stage 2 and stage 3 where, you're reaching death or a very high stage and very high medication, high cost and all that. But the real entry point is detection. Today, more than 50% of diabetes, more than 50% of hypertension in rural areas, and almost 100% of cancer is undetected at stage 1, that is at the preliminary stage. The reason is, and this is a very interesting reason, doctors should really identify this, unlike an infectious disease, when you get smallpox or you get any of these infections, you start coughing, doing, when you get diabetes, what happens? Nothing happens to you. You don't even know that you can continue to live. And old people live in slums. I was shocked when I was municipal commissioner in Mumbai that the diabetes load in slum areas is so high that people going in for dialysis for kidney failure because of complicated diabetes is huge. It was a survival line, the amount of dialysis centers which were running in slum areas. So detection at the stage before it becomes too visible and too painful, where of course it is detected automatically. So that is the real intervention. The way the Karkinos model of Venkat is working is he is trying to set up a very simplified process through visual and low-cost detection methodology. See, for breast cancer, you don't need biopsy all the time. 90% of the cases can be simply eliminated through physical but regular examination. Same for cervical cancer, same for oral cancer. These are just 3 things for all the other. So if the private sector can invest not in large cities, but in smaller towns, in state of detection, which are connected to the AI or digital stack, which now most primary health centers are digitally connected, so that they can get the patient load from there, provide valuable diagnostic insights at cost to rule out, things like cervical cancer, oral cancer, and the ones which get detected, then they travel up the line in terms of cure and treatment. So this is the model which I feel is workable immediately. Then the long-term management is, of course, there are issues about protocol, IT, which giving an update to the patient. You take your medicine on time, you do this. Those sort of things are there in terms of management on a long-term basis.
Understood. Thank you so much. Let me pick on one of the points that Sudha made earlier. I think is related to this discussion about value-based care. So while we understand management will have to be done over a period of time as cases get diagnosed, and Mr. Pradeshi also said it may not be very profitable. However, if we don't invest in disease management now, both in public as well as private sector, then all these insurance schemes that we have and the insurance programs we have, so now we are digging a deeper hole for ourselves. And you being a health economist, I think you would be right person to try and answer this question of where can we go now in terms of public financing of healthcare? How do we make that pivot? And maybe the value-based care initiative at NHA can be an example.
I think there's always an unmet need of healthcare. So whatever is currently already, identified patients, they will need care. So we can't say we will not manage them or we cannot, provide them care. So we have to start with actually already identified and definitely continue care for them. But what also is important is identifying them earlier and linking them with the health centers and whatever Praveen's said. So it has to go hand in hand. So that is one of the reasons the Ayushman Bharat program is not just about hospitalization PMJY. So it has another pillar which is mainly on the health and wellness centers, and where actually the 12 comprehensive primary healthcare services needs to be provided. It's not being provided to the level expected is a different, it still needs a lot of work in that area. But these things has to go hand in hand. And one of the new concept that has come up is the avoidable hospitalizations. How do we identify these avoidable hospitalizations and ambulatory care sensitive conditions? Because we need to make sure that we don't want people who can be treated at home, treated with the conservative management, landing in hospitals and getting admitted, and then again be paying for those services. So it's important that how do we ensure that we are able to detect these tracer conditions, which will ensure that these people will not need hospitalization. So we need to bring in that level of, strengthen the primary care to the extent, because when we say UHC, when we say healthcare, it is not just about hospitalization. So hospitalization is important mainly because it leads to poverty, it leads to catastrophic expenditure. So that is where we are trying to address it first. But these primary healthcare conditions are also leading to catastrophic expenditures, mainly for long-term chronic diseases and the kind of medications and treatments that they need to undergo, even though they are not admitted in a hospital. So in that sense, we need to have a balance of both the primary care track that is supposed to be ministry led and more from the government provision care needs to be also strengthened, whereas this hospitalization care, I think both public and private have equal stakes in that, and they both should improvise on providing. And private sector, I would always say that as a government, when we are the payer, we have to strategically purchase the services. So it need not be like we open up private care for hospitalizations for simple fever, right? So are we selectively purchasing is also very important. Only kind of conditions which cannot be handled by a public healthcare sector, or because the load is so much, for example, cataract. So even though we have can be done in both public and private, what we see is the load is quite high for the available public health specialist, ophthalmologist to handle the load. So we open those things up. So it has to be very selective, and we need to ensure that we are strategically purchasing these services from the private sector and not just free for all kind of things, especially when the government is a payer. Public can go to private or if they are paying out of pocket, but it is important that we need to ensure availability so that even the public can reduce their out of pocket expenditure.
I had just one point, to add to what you were saying. That the way to reduce hospitalization, of course, that's the key thing to reduce catastrophic expenditure. But if you see the difference between, let's say, Denmark, I just know a lot about Denmark because my sister just happens to practice there on gynecology. So whenever she comes to India, the biggest problem that and she's trying to work on this issue, is least invasive techniques. So if you will see, even the sugarcane workers, if a woman has the smallest problem, a gynecological problem, simply they just advise remove the uterus, remove the... Now that happens for every single type of intervention. If you talk about a small pain in the shoulder, they'll talk about shoulder replacement or a knee replacement. Now this is nothing which is coming from the public sector. It has to be an ethics. No, it doesn't happen in even in the most competitive private sectors like in US. It doesn't happen that they will go for the most intrusive intervention when it can be treated with a much lesser intrusion, whatever the funding difference between the two. So this is one ethics which, of course, government may try somehow, but there is a lot of self-discipline on this which should happen. Like we will know a doctor in Mumbai, like Dr. Bhojraj, who will never do a back surgery unless it's really needed, whatever the cost. On the other hand, you walk into any other hospital and the first thing they will recommend on the smallest is go for a spine surgery because he's done 20,000. How do you stop that?
Yeah. I have a slightly different take on it, Mr. Pradeshi, and I hope I can bring the panelists into this, is the reason why private sector goes on doing those things that you just described is because that today is a proven business model. And hence my challenge always to people that I talk to is, can we create a business model around not only minimally invasive surgeries or interventions, but reducing hospitalization? So the one question to you, and because the theme is 2047, right? Can you conceive of a future where the health and wellness center arm that you described is itself expanded into private sector? Can you imagine a world where the government contracts with private chains of primary care clinics to avoid hospitalization, one? And second, because it's 2047, so we can do blue sky thinking, yeah? So that's the allowance we have. And the second is, rather than package rates for hospitalization, can we move towards broader and broader? You know, we've talked about this earlier also, right? Where at least you get to episode-based payment, pre-hospitalization, hospitalization, post-hospitalization, and who knows, maybe later. And 2047, so feel free to...
Definitely. I think as countries are announcing for universal health care and making sure that it's not just hospitalization care. See, that's the first step in any UHC is to address the hospitalization care. But UHC means it is beyond an episode of hospitalization. So we are looking at when governments commit that we are doing UHC and it's going to be, including OP care. I think definitely private sector will be a part of that because, if everyone is covered under and there's nothing that they were going to have a out-of-pocket expenditure. So all private sector will also be part of this whole system, and definitely contracting primary care providers is already tried in many countries and it has been found successful also. Still, there is a little bit of hesitancy within our country, but I think in future, as we move ahead, there will be lots of opportunities to work on that.
Talk about the hesitancy.
Okay, hesitancy.
Bring out the dark side now.
The hesitancy, the main reason is because the ministry and the Department of Health has already invested so much in the public health system. So bypassing the public health system and opening it up to a private sector, even at the primary health care, would mean that there's a lot of things that needs to change at the policy level. So it would take a lot of time for them to understand and also do it in the right way, because it's not just saying that I'm very open and we'll start doing this tomorrow, but because of the investments that the governments have already done in the public health system, and there's always this focus that yes, strengthen public health system. So definitely private sector, they want to look as partners, but just opening up for everything as a private, they don't know how to control. So they have to also learn how to get in regulations, how the checks and balances needs to be put in place, even to engage the private sector. So all those things will have to happen on a gradual pace. So that is the hesitancy, not because it is not possible or I don't agree with it or anything like it's not a personal choice, but it's because the ecosystem has to build on a little bit more time and people have to engage with that a little bit more. So another thing I would like to also say is that how do we pay when we look at futuristic 2047, how do we pay these private providers is also something that is going to change. So currently, we, the World Bank team, we are supporting the National Health Authority in the diagnosis-related group of payments, a DRG payment system, which will be very much adaptable for the payments for even outpatients. Because what you said, the episode payments, the kind of, bundled payments, which is more rational and, patient-centric, because each patient will get a different set of rate based on the comorbidities and the severity of his condition. So we are doing the pilot in 5 states. So I'm sure that by 2047, even the hospitalization payment systems and the engagement of the providers. And one of the main concerns the providers get back to us is you pay us a flat rate, right? Because not all patients are the same and not all the care and the resources that we need to engage and manage a patient are the same, but you give us the same irrespective of whether the patient is a 25-year-old young adult or an 80-year-old with all sorts of comorbidities, I still get the same rate. So we want to address that, and that work is happening, and I'm sure that there's a buy-in from the government to look at it and try this system out. But still in a pilot stage, so we are still addressing the the building blocks of a DRG payments coding. I think that is again one thing we want private sector to engage more, is to have a proper diagnosis and a proper coding, so that in future you're ready for the kind of changes that are coming up.
Thank you. One of the things that comes out of Sudha's comment is, and I see this often in the health sector, is things are very complex. Okay, so all this thing that she mentioned about DRGs is a new world for us. But I don't think there is a way out of this complexity other than embracing it. So I've also heard comments that people say, oh, no, that's too complicated. Let's not do that. We have to do it, because otherwise you're going to see a suboptimal private sector engagement, as Sudha described. So not only embracing complexity, but being able to explain complex concepts in simple terms to people who may not understand that is crucial to get people on board and to have this engagement. Sticking with complexity, Shibu, your new role is quite in a complex world. It's on artificial intelligence.
Correct.
And I know a little bit about Cure AI. While it's a private startup entity, they still engage a lot with government and public health to solve public health problems using AI. What has been your experience in that new role, and what sort of partnerships are being struck, and what kind of partnerships need to be struck? And this is a theme carrying over from the last session, if you were here, which is technology is rapidly evolving, a lot of it coming from the private sector, and policy people and government people need to keep pace with it.
Yeah. So primarily we are focusing on image interpretation, so largely on radiological images, and our flagship product is chest X-ray interpretation. We have 22 different findings which are CE certified. A couple of them are FDA, and tuberculosis is actually WHO endorsed, and we scaled up in 50 plus countries. And that is where actually we started. Actually, start with one disease, as we tested in the PPIA sector, also start with one disease. And the best example for that, for the PPP, is government of Karnataka now embraced with detecting lung nodules, early lung nodules, that Mr. Praveen also kind of alluded on, the early detection. I would say that is something, early detection is something which is in sync with the government cost reduction measures also. So we have a partnership with AstraZeneca, where AstraZeneca pays us for our license for deploying the solutions in the public sector, right? So X-rays taken for any causes, like for X-ray, 1.2 billion X-rays are taken in this country annually, to billion. And from that, how many incidental cases you could find? So because these are incidental, are typically early detection. So when I say early detection, this is 6 millimeter to 30 millimeter nodule, which is probably like the radiologist also might miss. And X-ray is being a tool of a test ordering doctor, never a tool of a radiologist. It won't go to a radiologist to get typically reported. It will get reported for just compliance part of it. Otherwise, it's the doctor's tool. So that is where they see value. So the private sees a value in business in that, because the early detection, their molecule works better. The government sees value in, like, I don't want to end up in paying a lot, investing a lot in curing my patient with a late stage lung cancer. So starting from TB, they are learning lessons to detect more diseases. Similarly, X-ray also flashes cardiac failure, like potential signs of cardiothoracic ratio increase. So can we pick up incident of that and start actually evaluating that patient with echocardiogram, and then detect early heart diseases, or even start? I think the entire domain will get changed from the technology standpoint, much more focused, which also empowers our health and wellness centers for that matter. All these 12 modules will get eventually kind of paraphrased by a long language model to be an ease of using, because the frontline health worker could use that in a manner where he or she can actually kind of converse with the technology and also probably refer at the timely. So early detection, timely referrals, and also hidden information. So we have been doing n number of investigation which has not been followed up. So take a single use case of creatine. Creatine has been done left and right. Follow-up of every creatine, abnormal creatine, and judiciously, you might end up in picking up cases of early kidney damage, right? So that's the power of AI, is that pull that text of creatinine abnormality and push it to a system so that they can take action and follow up with the patient. So you won't end up in invasive. That's a PPP model in 2047 we are thinking about. How we can actually derive data insights using AI and work with the government for early detection and then bringing down the entire cost of healthcare and being democratizing whatever it is. Thank you so much.
Thank you, Shibu. If you were curious as to why all the corporate lab chains are investing in AI, you have the answer. Okay, because they are sitting on a lot of incidental findings that may lead to early action. I really like this partnership that you mentioned with AstraZeneca because again, it's a win-win-win. Right? There are 3-4 different stakeholders, but everyone has a win in there. So you do this incidental finding, and then that helps to improve the effectiveness of drugs, which is good for that business. And so they say, we will pay you the license, your license fee, which the government may not necessarily be paid. So is that how it is working together?
Yes.
Yeah. So again, I think these public-private partnerships or engagements may not again be simple. It may not be one-on-one. And in health, we see multiple stakeholders. All of them have some stake in the pie. Question is, how do we again redivide the pie while improving health outcomes in the long run? Thank you. Excellent. I am a little mindful of time, and before I get a slap on my wrist, I want to come to we'll come to audience questions. But I want to pose this question back. So we started with some research. We tied it with practical issues on the ground. Not that the research was detached from practice, but we went and dived into practice. For the next 5-10 years, from your perspective, how do we set research agenda? If I were to run this session again in 5 years, what kind of evidence would you like to see on public-private partnerships in health that today we don't know, but knowing that evidence will then fuel policy even further? So first, Shibu, you could go, Sudha next, and then in the end, I'll go to Pradeshi.
I would say data again, because you started with your presentation on the drug sales information. So can you overlay drug sales information can you overlay health, uptake of the health, and also with climate change information, like information of air quality. So and the next pandemic is also predicted for actually respiratory thing. Okay, so you monitoring your lung health over a period of time and overlaying multiple data sets, and you can actually see that whether your impressions of your X-ray in this week versus the last week was different, whether your ICU admissions pattern is getting different, whether your paracetamol consumption is going up. So this requires actually PPP model, because there is no standalone private sector cannot do it. And then overlaying air quality index and say, okay, your air quality index over this period probably will affect your lungs in a bad way after this period, and your measures taking how it is impacting. I think, and again, it also actually throws value for pandemic preparedness. Like your early warning signs might actually reflect it as an increased paracetamol consumption or sales, and you see a pattern of increased footfalls in your hospital. You see pattern of ICU admissions, X-rays are different. Okay, so I think that is something which I'm looking at as a futuristic research opportunity by bringing in multiple data sets and data insights for larger pandemic preparedness.
Thank you, Shibu. I mean, what that tells me is, don't think about PPP in health only involving private health providers. You may be in another sector. You may have a device for air quality measurement, and you may start to develop a partnership with the health department because they can use it to improve health interventions. Thank you, Shibu. Sudha, any thoughts?
I think it's very important for the next few years to look at the kind of policies and how much has been actually implemented. I think it's important that the policy research agenda needs to be strengthened, because people are very clear. We announced this, it's fine. We are doing, what we can. But it is important that what are the challenges and what are the enablers or influencers of implementing these, including the NHP. Because 2017 NHP has promised a lot of things. So we need to be very sure that the various ministries within the health also come up, including other sector ministries, keep coming up with a lot of, targets and, announcements. So it's important for us that what is it, how is it moving towards, and will it help us to reach the level that we want to is one. Within the health, something that I feel very strongly is also the kind of the patient perspectives in healthcare. I think when we came up with a value-based care approach, it was the patient at the center and what is his experiences within the health center, because and it needs to be done in a much more refined way, because this general patient satisfaction surveys happen, everybody 90% is satisfied, but we have to go a little bit more in depth to understand what is the change, what is the impact of the healthcare, and what were the issues for the patient too in terms of accessing the care and continuing their care. I think people-centered or the patient-centered approaches, though it's accepted as a policy and it's mentioned in many documents, it's not gaining that kind of thing because we don't know how to measure it or how to see the progress towards it. I think these two would be good.
Thank you. So one is system implementation science approach to saying those policies, are they really getting implemented? Second is a behavioral science approach to say how do you really involve patient in care delivery decisions even.
Yeah, and outcomes is also dependent on how the patient adheres to his care.
Correct.
So we need to bring in that perspective also.
Thank you. Last quick question to Mr. Pradeshi. As you being part of the capacity building commission, what kind of things can an educational institution like ours do to enhance capacity of public sector to take on more complex private sector engagement models? Any thoughts on capacity building? You're on mute if you're speaking.
It's talking.
That's us.
Okay.
Okay. Maybe we will get him online in a few minutes, but until then, maybe open up to audience questions.